So, well, I mean, we've said it here before, and I've said it to you in private. It is very stimulating, interesting. It's the where, I mean, it's, that's an explanation of kind of how, even me personally, why why I wanted to be a chiropractor, or at least in healthcare, because I was always interested in, I want to know how everything works. I want to know how
Mhm.
things work,
Mhm.
and then obviously you can fix them. But so, with that explanation, it's, well, why do they have knee pain? I'm coming up with all these
Mhm.
reasons and ways on how this can happen, and then how I can test it and how I can treat it. And that is how it happens. But then there is what I've talked about with you before, the practical problem of, at least in my clinical experience, I don't get to see these people that often. So then I'm going to devote, I should, and I do. I mean, I think I'm not giving myself enough credit, but it's like, I will go down a rabbit hole on the wrist and look up everything on the wrist and write out my own little notes and power. And then
Mhm.
I don't see a wrist patient for 6 months.
That's true.
Not one
That's
person.
true. And I don't
So,
think that ever changes.
well, I guess I would say it changes for you because
Okay.
I know how you practice and the patients you treat, in that, number one, every single one of your patients is getting a significant amount of time.
Mhm.
And that allows you to really check a whole bunch of things
Mhm.
and include a bunch of things within a treatment.
Mhm.
So while you might not say that you don't have you have a wrist patient every 6 months,
Mhm.
you're looking at their wrist function and considering the wrist on a lot of people.
That's right.
Whereas, today I can say, I might have treated 10 patients. Did I touch somebody's wrist? Not, I mean, not in any real serious way. Did I think about anybody's? No, I didn't. And I'm not
Mhm.
going to think about one tomorrow either. Whereas
Mhm.
I'm sure you probably did touch somebody's wrist today. So this is just my bullshit reasoning on why I'm not an expert on the wrist. Is because
No,
I can
well, you
study it
see,
all I want,
it
and
boils
then it
again.
goes away.
It boils down again to somewhat to practice style,
Yeah. Yeah.
because there were times when, as I was building my practice and also building this approach and this integrative approach, I would want to just not look at the wrist. I just wanted to do the simplest thing. I used to go, can I not just have a sprained ankle that I could go, oh, it's your ankle, and just treat? No, because I go, no, in order to know what a sprained ankle can propagate throughout the whole body, you have to examine the whole body. You must force yourself to examine it. And then the next time you see an ankle, you examine the whole body again, and you see if your notes agree that there's a pattern of response that is in keeping with the presentation. And by this, you start to build up a global appreciation for any of the syndromes, whether it is the ankle joint, the knee, the elbow, and so on.
Right.
Because you start to go, yes, when the ankle is truly involved, this is what you see. That helps you also when you go, it's not really your ankle. I know you have pain there, but the presentation is a little off.
Yeah.
So there's something different here. And I must ask myself why, even though it looks like a sprained ankle. And that is where it gets exciting, because you have a basis from which you can start, but you also have an inkling of what you are dealing with or not dealing with. And that is why you must be systematic in your examination. The exam must be unvaried, so that your collection of data is impartial to the area of concern. If your collection of data is partial to the area of concern, You will never learn to see the big picture and examine the patient from that aspect. And it will jerk you around during your treatment because you will have not sufficient data to make good clinical decisions. So that is
This
why,
goes back.
yeah,
No, I mean, that goes back to the idea that the assessment is the utmost primary, most important thing
absolutely,
that you have. The technique
absolutely.
and the treatment is almost secondary. It's the assessment, and you've honed a very good quality assessment, and the rationale for the assessment is all there. Uh, yeah, and again, and not to um, I don't know what the word is, denigrate myself, but that kind of thing of uh, knowing that, yeah, this is not really a problem of your shoulder. It is actually a neck problem. It doesn't make a difference if you're not complaining of a neck issue. I've proven it thoroughly to myself because I've gone through this exam and done these tests. That is something that happens, multiple times. I mean, almost every day in my practice, that I'm capable of ruling in and out uh, proximal problems. And most of the I mean, at least a lot of the times, they very much are not fundamentally proximal problems, but the proximal structures like the spine and pelvis have a lot to do with it. So I do make very quick, significant changes on people all the time that sometimes they're actually paying attention and they're like, holy cow, I don't, how did this, how did this happen? Why did this happen? And other times I have to turn to the patient and say, do you realize the miracle I just performed on you? Do you remember when your shoulder couldn't do this? It felt like this, you'd had no muscle strength, and all I did was do this with your neck and put you in this exercise position. Now everything is all better. You remember that? And then they go, oh yeah, it was like that. Thank you very much. So, it's but I guess the difficulty comes when, like we originally said, or like I originally said, when you have ruled out the proximal structures,
That's right.
and have to start to get into, is this a entrapment within the cubital tunnel?
That's
Then
right.
that is getting down to the nitty gritty, where I don't necessarily have the stuff right in my head at the moment. So then I go home and I read on it for the next week, and then the patient no call, no shows next visit, and then I never see a cubital tunnel ever
Again.
for another 6 months.
Yeah. So I must say I am deeply indebted to Dr. David Lee because he really opened my eyes
And that's a David
to
Leaf for everyone, a
to
chiropractor.
a chiropractor who had a remarkable ability to do neurological and clinical analysis. And that was the first time I thought, oh my gosh, this is the way to go. The ability to rule out systematically, working your way down the shoulder, into the elbow, into the arm, following the nerves, the muscles they innervate, the areas they innervate, the response of stressed ligaments, under stressed ligaments, how do they present? The fact that you could stress a ligament and stress it and make the muscle that crosses it go weak, and so on, to see if it was stable enough.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.